I think we be clear at the outset. We are here to talk about mpox Clade I. Yeah. Clade II has been in Singapore for over a year, largely not a public health threat, but what we are concerned about now is mpox Clade I that has broken out in many African countries. At some point, we should expect it to spread beyond Africa and then in Singapore. At some point, it will arrive. Yeah? So we have received many of your queries over the last week, so thank you for your interest. They're all very relevant questions, so we thought it's much better that we have a press conference so that everyone can be briefed on our response plan. So this plan that we are going to present to you or explain to you is based on what we know about the virus. Yeah? The virus have not spread to many countries yet, so we do not have full information on the characteristics of this virus, but we have good information on how it behaves, the key characteristics, which allow us to develop a response plan. So things can change as we understand the virus better as the situation evolves. And so our plans may have to adapt over time, but as of now, I think we have quite a comprehensive plan. I would say, bottom line is this. I think we were right to be worried about mpox Clade I. WHO was right to have declared it a PHEIC, but we think this is likely to be a troublesome virus that we can manage. It will very unlikely lead to the kind of disruption that happened during COVID-19. It's something that a troublesome virus that we can manage. As I explained earlier in Parliament, when we passed the amendments to the Infectious Diseases Act, the IDA, we provided for 4 levels of alert for Singapore. One is peacetime, then second, level 2, outbreak management, level 3, a threat. COVID-19 was a threat, if this law has been in place at that time, and finally, emergency, which we have not declared before. So 4 levels of alertness. Typically, we toggle between peacetime and outbreak management. We move to outbreak management when there's an incident, such as we have a TB outbreak in Jalan Bukit Merah, at the hawker center, ABC Hawker Center, or when mpox Clade II first arrived, and we don't know about it very much, we were in outbreak management mode. But typically, we toggle between these two, and the public don't even know. Yeah? We do not think there's a reason to elevate the level of alert beyond outbreak management for mpox Clade I. That said, we should not be complacent. We have been developing many contingency plans since the COVID-19 pandemic. It's time for us to dust off these plans and put some of them into action and implement them. And we must continue to monitor the situation and be prepared to respond, adapt, and even decisively implement certain measures should it be necessary. So today we have 2 other members in this panel. Dr. Mark Ho will present the situation around the world. I will then talk about the response plan, part of it, and part of it, particularly the community aspects. And then Professor Kenneth Mark will explain healthcare capacity, treatment, as well as vaccinations. Then we'll take your questions. Okay? So I will hand over to Dr. Mark Ho.
Thanks, Minister. I'll briefly cover some points about the virus, the disease, and the current situation. Mpox is caused by the monkeypox virus. The main symptom is rash, although it may start with fever, muscle aches, and swollen lymph nodes. The incubation period is long, typically from between 6 to 16 days, but can be up to 21 days. People are usually infectious from the time symptoms start until all the scabs have separated. That means fallen off naturally. And testing for mpox is done through polymerase chain reaction tests on the swabs of skin lesions. This is done through our National Public Health Laboratory, and they can distinguish between the 2 mpox clades. Now, the World Health Organization, or WHO, currently does not recommend the use of point-of-care rapid tests kits due to the lack of evidence on their diagnostic accuracy. There are two subtypes called clades of mpox, Clade I and Clade II. Symptoms are clinically indistinguishable, and historical data indicates that Clade I causes more severe disease than Clade II. Clade II has been circulating globally, including in Singapore, as part of the 2022 mpox multi-country outbreak. The concern currently is Clade I, where a large outbreak in the Democratic Republic of the Congo, or DRC, has exported cases to 4 neighboring countries, indicating cross-border spread and leading to an outbreak in Burundi. On 14th of August, the WHO declared this a public health emergency of international concern. As of 25th August, the DRC reported a cumulative total of over 22,000 cases and 610 deaths, and this is a marked increase compared to preceding years. Those younger than 15 years old represent 66% of cases and 82% of deaths. There are 2 countries outside Africa that have seen 1 case each of mpox Clade I, namely Sweden and Thailand. Both cases had recently visited affected countries in Africa, and both countries have not reported further local spread. You can see in this slide that the outbreak of mpox Clade I remains generally confined to Africa at the moment. And in comparison, there is a broader distribution of mpox Clade II globally. As of today, there have been no cases of mpox Clade I detected in Singapore. 14 confirmed cases of mpox have been detected this year, all of which are of the better understood and less severe Clade II infections. Based on the data we know now and the information we know now, the risk of Clade I importation from the outbreak countries into Singapore is considered low, as there are no direct flights from affected countries and the travel volume between Africa to Singapore is low. As we have seen with the cases in Sweden and Thailand, sporadic exported cases globally are to be expected. But as long as these cases do not spread in their respective countries, the risk to Singapore does not change significantly. While there are no mpox Clade I cases in Singapore to date, over the next few months, we need to be alert for any potential threats that will increase the risk to Singapore. Our healthcare system remains primed from the 2022 mpox Clade II epidemic and has the capability to effectively diagnose and manage mpox infections. MOH will continue to monitor the mpox situation closely over the next few months for spread to countries with high connectivity to Singapore and for better data on disease characteristics. Minister, please.
Thank you, Mark. I will talk about our response plan, the various aspects. I think the first important rule is to recognize that every virus is different. They got different characteristics, and we must respond accordingly based on those characteristics. Never fall into the trap of fighting the last war. And just because in the last pandemic we did that, so now we must do the same. All depends on the characteristics of the virus and what are we dealing with. So let me summarize the key characteristics of mpox Clade I. First is the transmission mode. Transmission mode is mainly through close physical contact with infected persons. And this includes sexual contact, mouth to mouth, skin to mouth, skin to skin contact. Yeah. What makes Clade I different from Clade II is that the global outbreak of Clade II is mostly amongst men who have sexual relationship with men, yeah, within those circuits. However, Clade I in DRC spread not just through sexual workers and sexual networks, or I should say, it doesn't spread primarily through just sexual networks, but also through family members living in the same household, where there will be some close and physical contact. is a question that scientists are looking at is whether it's spread via air, just like respiratory illnesses and diseases. It cannot be ruled out, but this will be something that will be clear in the coming months. But I think what is clear is that it doesn't spread as far and wide like COVID-19, where one person, say, singing in a concert hall can spread to many members of the audience. This is very unlikely the case for mpox Clade I. The second characteristics we should look at, pay attention to, and in fact quite decisive, is the infectiousness. And this is measured by what we call a reproduction number, which is R. So as of now, mpox Clade I has a known R of about 1.3. This means for every 10%, they can spread to 13%. Compared to COVID-19, mpox Clade I is far less infectious. For COVID-19 Omicron variant, for example, one person can spread to 5, 8, or even 10 people. And because of that high level of transmission, we require all kinds of safe management measures and even a circuit breaker in order to slow down the transmission. We are not seeing that in mpox Clade I. This is quite a decisive factor as we develop the response plan. The third characteristic we look at is severity. So out of 100 cases, infected cases in the Democratic Republic of Congo, DRC, about 3 to 4 died, which is actually quite a high number and quite a worrying number. And as Mark presented, a majority are actually young people below 15. The actual statistics, when it comes to Europe, developed countries, and to Singapore, is likely to be significantly lower for two reasons. Number one is that in Africa and in DRC, the denominator is probably underestimated because many infected cases are not detected nor notified. So bigger denominator, actually the severity rate should be lower than 3 to 4. And secondly is there will be better access to quality medical care in Europe or in Singapore, which will lower the severity rate also significantly. Fourth characteristics, which are the specific groups that will especially be affected by mpox Clade I. The first group is, of course, the vulnerable, meaning the old, the sick, or people who are immunocompromised. Second group is possibly the young, because as mentioned, a large proportion of cases and deaths in the DRC are children below the age of 15. And there are other factors and reasons for the high severity observed in children in the DRC. For example, there's a high prevalence of malnutrition in the DRC. The children may also be infected with other diseases. Thirdly, they may not have access to good quality health care. All three factors are critically important to children when they are infected with a disease like mpox Clade I. We believe the clinical outcomes will be quite different outside of the DRC and certainly will be better in Singapore. That said, this is an area of risk that we need to pay attention to. To protect these groups, these vulnerable groups, we should not resort to draconian and very disruptive measures like what we did during COVID-19. No countries are doing that now. The best way is to suppress the spread of the virus, provide proper treatment to those who are infected, and have a very effective vaccine strategy. So this brings me to our response plan. There are a few aspects to the response plan. I'll present it together with Professor Kenneth Mark. Number one will be border measures. Since COVID, we have never gotten rid of electronic declaration when you arrive in Singapore. It's precisely for a situation like this. Don't step it down and then having to step up again. We just kept it simple, 2 questions, in order to have some border surveillance of people coming in, including Singaporeans coming back. We have enhanced the electronic health declaration through the SG arrival card. Travelers now, for those who have recently traveled, you will notice we do ask very prominently, do you have rash? Yeah, we've started that for some time. And to also declare other mpox-related symptoms. as well as your travel history to affected areas. We have put in place temperature and visual screening for symptoms for persons arriving from higher risk areas, both at the air as well as the sea checkpoints. Symptomatic travelers, they will be assessed by doctors at the borders and, if necessary, transferred to hospitals for further assessment and testing. Second area will be contact tracing and quarantine. mpox, as Mark has explained, has a fairly long incubation period, up to 21 days. And so cases may not be picked up at the borders, even if someone is infected. So chances are it will develop after they enter the border. So our clinics have been notified and will be on alert to spot such cases and immediately report to MOH whenever there is a detection and they see symptoms that they suspect might be mpox or mpox Clade I in particular. Should they detect a case, existing contact tracing and quarantine protocols will kick in. All suspected mpox Clade I cases will be conveyed to a designated healthcare facility, likely a hospital as a start, for further assessment and testing. And if tested positive, these patients will be treated and isolated until they are no longer infectious. Then contact tracing will be triggered and conducted for all these confirmed cases of mpox, and this is actually a very effective way to limit transmission and drive the R lower. NEA, National Environment Agency, will then oversee environmental cleaning and disinfect all the key areas that the infected persons have been to in recent days. Quarantine will then also be activated. It will be in a designated government quarantine facility. Duration will be set at 21 days for now, because that is the incubation period that we know. But it starts from the day of exposure. Yeah, so for the great majority of people quarantined, not likely they will serve the full 21 days. Yeah. So it starts from the last day of exposure to the confirmed case. Yeah. So persons under quarantine will be offered vaccination to reduce the risk of infection. This is something that Professor Kenneth Mark will explain and talk about later. It's a very important step. Third area, migrant workers dormitories. We have been working with the Ministry of Manpower to develop various contingency plans since COVID-19 pandemic, and some of the measures have been activated in the foreign workers dormitory. And this include, one, wastewater testing. This is being conducted at 120 dormitories currently, and also at the onboard center. It can be a useful way to give us an early warning. Two, temperature and visual screening for newly arrived work permit holders at the onboard center. And thirdly, triggering existing protocols which will track, trace, isolate workers in the dormitories and to support workers in their recovery. And so this is actually a very important system that has been put in place since COVID-19, where infected workers have their spaces available within the dormitories to isolate infected workers, so that it doesn't spread further within the dormitories. Fourth area of response is preschools and schools. We have also been working closely with MOE and ACDA to put in place contingency plans since the COVID-19 pandemic. Schools have actually quite effective existing protocols to manage outbreaks, such as hand-foot-mouth disease, and they are relevant in countering mpox Clade I. These include ensuring good hygiene practices among the students, screening the students for symptoms. And if there is an infected case, the student will be isolated, the premises will be cleaned, contact tracing will be triggered, and if necessary, the class, the level, or the school may be temporarily closed to prevent further transmission. These are all actually in place to manage, say, hand-foot-mouth disease, and they will be relevant for mpox Clade I as well. As mentioned earlier, given the characteristics of mpox Clade I, the most effective way to protect our children is to have a good response plan that will suppress the transmission of mpox Clade I through sensible measures community measures, contact tracing, and isolation. Fifth area, masking. As I mentioned earlier, based on what we know now, Clade I mpox is spread mainly through close physical contact with infected individuals. Is there transmission through the air? This is a question that's uncertain. We cannot rule that out, but it is quite likely that it is not the primary mode of transmission. If that is the case, people who are well do not need to wear a mask. There's not necessary for MOH to impose a masking requirement on people who are well. However, should there be evidence of significant respiratory transmission, such as beyond a household into, say, public areas, then we need to reevaluate this policy. And one step we can consider then is to require masking on public transport or indoor crowded spaces. But as of now, this is a question mark. I think more evidence will emerge in the coming weeks and months. Our current mask stockpiles and local manufacturing capabilities will assure us of adequate supply. I will now hand over to DGH, Kenneth Mark, to elaborate on healthcare capacity, treatment, and vaccination strategy.
Thank you very much, Minister. I'll first elaborate on how we will manage Clade I infected cases and address the question of whether our healthcare capacity is sufficient to do so. Minister has shared earlier that rapid and widespread community transmission similar to COVID-19 is unlikely, given the effective reproduction number of 1.3 is low compared to COVID-19. And as Minister had shared earlier, all cases that test positive for Clade I will be managed in healthcare facilities where there are stringent infection prevention and control measures in place. And these cases will be isolated until no longer infectious. Based on what we currently know of the Clade I virus, our existing hospital capacity, including our ICUs, remains adequate to treat and isolate infectious cases. On treatment, the goal of treating mpox infection is to manage symptoms, including the rash, managing pain, and preventing complications. And while there are currently no specific therapeutic options approved for the treatment of mpox infection, international healthcare authorities and jurisdictions, such as the United States Centers for Disease Control and Prevention and the United Kingdom Health Security Agency, have recommended antivirals which were originally indicated for smallpox infection, such as tecovirimat, for the treatment of mpox infected cases, with conditions that cause a weakened immune system for patients who are suffering from severe disease or have skin conditions, active skin conditions, which compromise the integrity of their skin. On vaccination, there has been good evidence that demonstrates smallpox vaccination rendering cross-protection against mpox infection. And since smallpox vaccination was required in Singapore until early 1981, there will be some mpox immunity and protection among Singaporeans aged 45 years and above. Given that smallpox was such a dangerous disease, Singapore continues to keep some smallpox vaccines even when smallpox has been eradicated. And these vaccines can also be used against other similar orthopox viruses such as mpox. The main vaccine to be used against mpox is Jynneos, a third-generation smallpox vaccine with a better safety profile compared to previous vaccines. Based on the current understanding of the disease epidemiology of mpox, Clade I, population-wide mpox vaccination is not recommended for now. There are also no vaccination recommendations for travelers going to these affected countries. Our current vaccination approach focuses on post-exposure prophylaxis, or PEP, of close contacts of mpox cases, as they are the highest risk for developing infection. A single dose of the Jynneos vaccine will be offered and should be given within 14 days from the time of exposure. For healthcare workers, personal protective equipment, or PPE, together with infection control protocols, remains the key mode of prevention. Nevertheless, to further protect our healthcare workers, who are at the highest risk of exposure to confirmed mpox Clade I cases, such as those working in NCID or other designated healthcare facilities who need to render direct care for these patients and to be in very close contact with infected cases, we are offering pre-exposure prophylaxis or PREP to them. So based on this current vaccination approach, the existing supply of Jynneos vaccine in Singapore is projected to be sufficient. To better strengthen our preparedness and resilience, MOH is also looking at procuring more doses when available. We will continue to monitor the situation and to adjust our vaccination strategy as needed as the situation evolves. Minister.
Thank you, Kenneth. Just to repeat myself, bottom line, we think this is a troublesome virus, something we can manage. We will likely learn more about it in the coming weeks and months, and should be prepared to adapt our response plan as we understand the disease better. We'll be happy to take your questions now. Yes.
Vanessa from CNA Digital. May I just check about the vaccination? So you're going to be vaccinating two specific groups. Is this going to be compulsory for those groups? And what happens if phases want to take the vaccine? And when will you actually start vaccinating healthcare workers?
The vaccinations are offered to healthcare workers in the pre-exposure prophylactic setting, as well as to close contacts of confirmed infected cases in the post-exposure setting. The vaccinations are offered voluntarily, and both the healthcare workers and the close contacts have the discretion to decide whether to take up the offer or not. These vaccination policies are already in effect, and we've issued clinical guidelines to medical practitioners and healthcare institutions accordingly. So the healthcare workers who are designated to look after mpox cases can already take up this option for vaccination, and close contacts, as and when an infected case arises in Singapore, will be offered this option.
Also will be free. It will be free. Also bear in mind too, some may decide not to take it because if they are born after 1980, they're 45 or above, like us. We had smallpox vaccination at birth, so we will have some protection against mpox Clade I. Yes.
Tessa from the business time. Sorry, just another question on the vaccines. Are there other groups that you guys might prioritize if there are more doses, like maybe those that work at the airport, since they're also quite high of exposure to those that will be confirmed cases?
We have no current plans to offer vaccination beyond the groups that we have just identified, and this is in part related to our current understanding of the disease characteristics and how it transmits. This is very different from COVID-19, where the dominant form of transmission is through the airborne route. In contrast, for the mpox, it is mainly through contact, either with the skin of infected cases or contaminated surfaces after secretions from these infected cases have landed on those surfaces. The airborne transmission is a possibility, but as yet not quantified, and we do await further evidence. So on the basis of what we know, the risk is highest in those who are actually taking direct care of these people in the hospital and healthcare setting. So we do not at this time have any plans to vaccinate a larger pool of people beyond what I've just described, but we will continue to monitor the situation as our understanding of how transmission takes place. We will evolve and adjust our plans for vaccination accordingly.
There's a slight assumption in your question, wondering whether this is due to supply. I think it's due to necessity, based on the understanding of the disease. Because so far transmission is via close contact, skin to skin, mouth to mouth, mouth to skin. So if a setting doesn't require that, I think you're just wasting the vaccine. Whereas healthcare workers do have to attend to patients, do have to have physical contact, family members, very close contacts, possibly you can be infected. So these are the ones that we need to focus on. I keep emphasizing we have to have a response plan that suits the characteristic of the virus.
I'm Nazira from Medical Leaders. Again, on the vaccine, I want to clarify what you encourage those traveling to do mini pilgrimage to Mecca, for example, to take the mpox vaccination.
we have no recommendations to vaccinate travellers at this point in time. It is also not part of the recommendations that come out from the WHO or any of the international health authorities at this stage. Our understanding is that beyond the cases that have been reported or the one case reported in Thailand and Sweden, there are no documented cases that have been picked up in any other geographic setting beyond the African continent, the countries of concern. So traveling to the Middle East, whether it's for pilgrimage or other reasons, at this point in time is still deemed to be safe, and there are no specific recommendations for vaccinations for these travelers. Again, our policies may adjust based on our understanding of how the disease spreads and whether or not there is spread and local community transmission in countries beyond the African continent.
Bear in mind many travelers that go to Hajj or Umrah, they'll probably be 45 or above as well. So they will have gotten smallpox vaccination, which does act against mpox Clade I. But more importantly, is that again going back to the characteristics of the disease, at a R of 1.3 is not likely to be necessary to be given vaccination before you travel. Yes, Mothership.
Would there be a list of affected countries that will be provided for Singaporeans to avoid traveling to?
I don't think so. That would be quite drastic. No countries is doing that now. Again, the characteristics of the disease doesn't require us to do that. But strongly encourage that when people travel, take the necessary precautions, hygiene, don't touch too many things. If necessary, in a very crowded areas, you're not comfortable, can always wear a mask. I do know of people who always wear a mask when they travel, especially at the airport, because that's where different forms of diseases can be spread. So take all these sensible precautions. If the situation evolves, if there are additional risks that we know of, and then we'll update our response plan.
Sorry, can I also ask a bit more about contact tracing and whether something like the Trace Together would be implemented?
Again, going back to the characteristics of the disease, with an R of 1.3 amongst very close contact, we don't need a Trace Together. Right? Trace Together was useful during COVID because COVID can spread far and wide. A room like that with a person talking can spread to everybody. And therefore Trace Together becomes a very efficient, effective way of rounding up contacts. Sometimes not even close contact, just contacts of an infected person. In this case, we are looking at very close contacts. Skin to skin, mouth to mouth, mouth to skin. And therefore Trace Together would not be necessary.
Sure, I would like to ask, I understand there is no confirmed Clade I cases right now in Singapore, but are there any suspected cases or still undergoing any tests? Okay. And also the other thing about this Clade I, right? We keep emphasizing this is skin to skin, and there is no risk right now. But then what about those professions which requires more close contact, for example, manicure, pedicure, massage, that kind. So what are the precautionary measures? And then so lastly, Minister, could I ask for Chinese Novak?
I'll come back to the Chinese. What would you want me to say?
Maybe we talk about the risk of this virus as compared to people are worried whether this could play out as COVID-19, which is not.
Perhaps Minister, I'll first address the question concerning manicures and pedicures.
I mean, not only that.
But similar other non-healthcare settings where some level of skin contact actually has taken place. At this time, there's no necessity to be unduly alarmed, particularly if you're engaged in professions or these activities where some minimal skin contact does take place in the process of either delivering a service or care. Our understanding of the disease transmission actually does require some level of intensity, and that includes proximity and duration. So at this point in time, transient contacts are not as likely to increase the risk of transmission compared to prolonged contacts over a period of time, as well as close and physical contact during that prolonged duration as well. So on that basis, there are no specific recommendations for services and businesses where the services require some level of transient physical contact. So manicurists, pedicurists, I think at this point in time, no issues. However, it is not unreasonable for these businesses and services to think about generally some level of increase in hygiene standards, continuing to maintain, not necessarily for mpox, but necessarily as generally good hygiene practice that may, for example, involve the use of gloves, hygiene measures including washing of hands, and these simple measures already further reduce the risk of any infection that takes place for infections that are transmitted by skin contact. So that would be the general advice I give, but at this time our assessment is that these businesses and services do not pose an increased risk, and therefore no specific requirement is needed for these businesses compared to the measures we're taking in the healthcare setting.
Sorry, Prof, can I follow up? Because they are not transient, quite prolonged, but like the massage can be 1 hour and above at least.
Yeah. So as and when needed, based on case that arises and the close contact, we will adjust accordingly and assess whether or not these individuals require to be brought within our quarantine framework in order to monitor their health and to make sure that they don't get any infections. But beyond that, there's no special preventive action that needs to be taken by them, but the common and good hygiene practices continue to prevail.
Let me try to answer it a different way. It's like crime, right? The police always say low crime doesn't mean no crime, and therefore we should always be careful, don't leave our valuables around. So these are precautions that we take. Don't tempt people. But by and large, in Singapore, we are quite safe. Unlike some countries, you leave your car there, park, lock, somebody may break in and take it away. But in Singapore, we are able to do that without having, and we don't drive around Singapore worrying when will someone break my car. Why? Because overall, 治安好嘛, overall crime rate is low. So that provides the overall condition for us to live life quite normally without, there is some worry here and there, but we don't become too anxious about every setting. So I think it's a little bit similar that there are many, many instances where we do come into physical contact with other people through our work, with people, with loved ones, so on and so forth, with friends. We can be worried about all that, or we say let's create a condition such that we need not be overly anxious about all these settings. And that is having a good response plan that suppresses the transmission. If R is 1.3, with contact tracing, with border measures and other measures that we are thinking of, we can suppress it below 1. That means if mpox comes in, it will die out. It will die. It takes some time, but it will die out. Which means we can carry on life normally without worrying that every time I touch Canada, I'm worried. Yeah. So I think that's what we are trying to do. As opposed to trying to address every single setting where there is contact, try to address it at the higher level, suppress it. Yeah. Do you all know whether you had smallpox vaccination? You know, huh? Do you have smallpox? You don't have. You're born after. Yeah. Obviously, yes.
Okay, so I have a question.
So I was supposed to say something in Chinese, but just in case you all want to check, it's on your left. This little wrinkle, this little wrinkle oval-shaped scar, that is smallpox. Yeah, so I have. Yeah, so you can always check if your skin is smooth. No. All right. Okay. I have a script in Chinese. I think some of it should be relevant. Mainly, you want to know the overall assessment. 我们认为我们对这个 mpox Clade I 病毒感到担忧是正确的。世界卫生组织宣布mpox Clade I 是一个全球需要关注的公共卫生事件，我们也觉得是正确的。但是我们就根据现在对病毒的了解，做了一些研究，进一步的了解它。没有100%的了解，但是据我们现在的了解呢，我们觉得这个病毒是相当麻烦，但是是我们能够应付的一个病毒。它不大可能会成为像冠病一样，非常严重的 干扰到我们的生计或者我们的日常生活。我们需要铭记的就是每个病毒都不一样，不要打以前的仗，打今天的仗。每个病毒不一样，根据我们的了解去适当的、有效的去应付它。我们对病毒有几个在病毒呢有几个重要的特征，我们都需要去了解它。第一个就是怎么样传染呢？病毒这个 mpox Clade I 传染的方式，据我们现在的了解，就是密切接触，就是皮肤对皮肤、嘴对嘴或嘴对皮肤，这主要的感染方法。它不像就是在世界上播的 Clade II。Clade II 呢是通常在性行为，因为在性行为所导致的，所以 Clade I 的这个传播力会比较广泛一点，但是还是通过密切接触才会感染。我们暂时不能够排除这个病毒会不会从空气传染给其他的人，这是科学家继续需要研究的。但是呢，就算它又会通过空气传染，这不是它的主要途径。主要途径还是密切的接触。第二个特征是它的传染率。英文呢，我们就用 R 来评估这个传染速度。传染数。mpox Clade I 的 R 大概是1.3，就是说每10个人呢被感染的人呢，每感染的10个人会传给13个人。所以比起冠病，这个数字是少了很多。因为在冠病，每10个人可能会传染到50、80甚至100个人，这个是每10个人传染给13个人。我们在考虑、我们在制定我们的预防措施、应对措施时，这个传染率是一个非常重要的考量。第三呢，就是严重程度、杀伤力多大。现在在刚果呢，就 DRC。病例当中，每100个人有3到4个人死亡，这是相当高、相当令人担忧的一个数目。但是本地的数目肯定会比较低。第一呢，因为刚果呢还有一些没有被查出来的病例，所以你的病例多呢，其实它的这个严重率啊会减少。第二呢，被感染者在新加坡呢是比较容易得到优质的医疗服务，这也会降低它的严重程度。第4个特征是哪一些人会比较受影响，被这个 mpox Clade I 受影响？这当然包括弱势群体，这就包括了老年人，那些有患病的人，或者是抵抗力比较虚弱的人，也可能是年轻人。这一点我们比较关注，因为在刚果呢，许多病例，包括死亡的病例。包括了许多年龄少过15岁的年轻人，还有孩童。但这当中有很多原因，包括当地刚果的人民呢，普遍有这个营养不足的问题。小孩子呢也可能被感染了其他疾病，如麻疹。另外呢，当地人也可能比较不容易得到一些基本的医疗服务，这些对幼童、对年轻人来说是非常重要的。我们相信，在这个刚果以外的地方，患者的病情必然会不同。在新加坡的情况绝对会比较乐观，但是还是需要注意的一个风险。可以吗？
可以。
还需要吗？
可以。
Yes.
Now, a lot of the pictures of mpox sufferers, they have these huge bulbous pustules. But going through the US CDC photographs, there are different degrees of rashes. So the doctors on the front line, the GPs, trained to actually look at these different rashes rather than, for example, what my colleague from sub-editing who thought that we really need to see the huge lumps before you claim it's mpox.
So rash is one of the characteristic symptoms of mpox, and the rash changes over time. It starts off a bit flatter and then eventually turns into what you described, more pustular, before it sometimes bursts and then scaps over and then falls off. We have been issuing guidance to the doctors on how to manage mpox cases. The National Center for Infectious Diseases has also been helpful in issuing a joint guidance to doctors to teach them about the different types of rash at different stages so that they can identify these cases and to differentiate them from other forms of diseases that can also cause rash. So we are moving to increasing the understanding and being able to identify these rashes among our local doctors as well.
Two questions. One is that we've seen a lot of misinformation and fake news surrounding mpox. Okay? So how are we actually dealing with this? Because there's been a lot of news spread about how it's spread through men and sex of men, or through the respiratory transmission. Second one is, Minister, you mentioned that no other countries are taking draconian measures. But given that Singapore is a global hub, is Singapore actually prepared to be the first country to implement such measures if the need arises?
I'm sorry, I wasn't monitoring social media so much. What are the misinformation that is out there that is quite viral? Sorry?
The way
it's spread? Okay.
And then also perhaps some blaming of who might be responsible, which is the men.
Okay. Well, if it's something very viral and starting to affect public sentiments, public level anxiety, I think we'll see what we can do about those. But as of now, a press conference like this, I think, is useful. At least put out the right information, with the right coverage, go out to the public to raise everyone's awareness and understanding of the disease. That's probably the first thing we should do. And in the coming few days, I'm sure there are more questions, and we'll answer them as much as we can to raise the understanding. That's probably the best way to respond to those misinformation now. As to whether Singapore is prepared to be the first country, when necessary, I think don't be the first for the sake of being first. As it is, I think we are the first country to sit at a press conference, explain the characteristics of the disease, and explain based on those characteristics, this is what we're going to do about it, and there's a certain logic to it. I think we are probably the first to do so, even though not likely we will be the first to be infected or to have an infected case outside of Africa. But never be afraid to be the first to do what is right, but don't be the first for the sake of being the first. Okay, sorry.
Were there any asymptomatic cases, and were they all reported cases, and how many are locally transmitted? And in terms of severity, any of them actually require ICU admission?
I'll take the case, and Dr. Koh can expand if needed. The 14 cases that you described, actually, the 14 cases that have been picked up this year, and they come up and were reported to us from doctors who have actually picked this up in their clinics based on patients presenting with symptoms. And all of them have symptoms. All of them have not had severe illness. And in fact, the cases today, they actually all have either recovered or in the process towards making a good recovery. So that's the situation as is now. The 14 cases reflect the cases we picked up of Clade II infection in Singapore this year, but it does not reflect the overall number of cases that we've seen. From the first case that we've seen in 2019 of an mpox case, and subsequently we actually do see on a year-to-year basis some cases emerging, and this is part of that general trend. We've not picked up that as far as Clade II infection is concerned, that this is increasing or worsening in Singapore. So that would be the situation it is now. There are cases that are reported to both the NCID and us, where in addition to patients having symptoms that raise a concern about possible mpox disease, they may have perhaps some travel history. And then we are investigating to make sure that there's no Clade I infection. All these cases consistently have tested negative. So we are quite confident at this point in time that we have not picked up any Clade I infection, and all the cases to date remain Clade II.
So maybe just to add on to Professor Mark, the cases that we are seeing have been in younger persons, young adults type of persons, and generally healthy. And therefore, we have not had any ICU or deaths from mpox Clade II. Mpox has been a notifiable disease since the 2022 outbreak that affected countries around the world. So our doctors have been informing us when they do come across these cases of mpox Clade II. And that's how we know of these cases.
Okay. Yes.
For example, going back to the vaccine for healthcare workers in close contacts, do you have a number of how many healthcare workers in Canada will be looking at that will be offered the vaccine? And will they be offered just one or two doses? And for close contact cases, I understand that the vaccination currently is recommended for 2 doses. Is there any considerations for offering just one at the moment?
We don't have the numbers of healthcare workers that have already received the vaccination, and this may be an evolving number as the offer for vaccination for staff who are looking after mpox cases increases. And so that data is not available to us at this point in time. For healthcare workers, for vaccination against mpox, the full regime is still a 2-dose regime, separated by about 28 days between the first and the second dose. But given the fact that a significant proportion of our population have already been vaccinated against smallpox in the past, as Dr. Hu had mentioned, generally those were Singaporeans above the age of 45 would have received a smallpox vaccination already. We have discussed and consulted our expert committee on immunization, and the evidence today suggests that those who have received smallpox vaccination in the past already have a significant degree of protection against mpox infection. And therefore, the recommendations that have come to us through our expert committee is that one additional dose would suffice to give them enhanced protection against the mpox infection, as opposed to the full 2-dose regime that described for full vaccination against mpox infection. So healthcare workers above the age of 45 will be given that 1 dose, respecting that they have already received smallpox vaccination in the past. But if they have not received smallpox vaccination in the past, or they are less than 45 years of age, the pre-exposure prophylaxis will consist of the 2-dose regime. So for close contacts, bear in mind that the importance is, in fact, to protect them from getting infection within the period of exposure and the incubation period. The current regime, as recommended and endorsed by our expert committee for immunization, is to offer them that 1 dose that gives them the protection during this incubation period phase. Given that the second dose occurs 28 days later, well beyond the incubation period, it will be clear by then whether or not the person actually has infection or not, and there's therefore no absolute requirement to give them that protection against this particular exposure to follow through as a second dose. So the current regime for post-exposure prophylaxis consists also of that 1 dose.
Okay.
From Singapore, I just want to ask that for vulnerable groups like elderly people or like younger kids, since there is no measure for them now, anything that they could do to sort of protect themselves for the time being?
Kenneth can add. I think the usual steps to take to make sure that one stays healthy and free of diseases. Observing hygiene for kids is actually very important. Ensuring the child has a balanced meal, have exercise, lead a healthy life, and therefore your immunity goes up. Yeah. And try to get rid of bad habits, sucking your thumb, rubbing your eyes, things like that can all increase the risk of being infected with diseases that you don't want. And if you are sick in some way, avoid going to school as far as possible. Anything else you want to add?
I think as Minister had mentioned, in the situation of Africa, many of the children had higher, more severe outcomes, in part because of malnutrition and other infections. So keeping a healthy lifestyle would help for the children. For the elderly, the same thing applies, that they should keep a healthy lifestyle, and if they are vulnerable when they go to crowded locations, then they may want to protect themselves by wearing a mask if they feel that they don't want to catch infections from others. But otherwise, they can just continue to lead their normal lifestyles.
So what is important is to understand that government, MOE, ACDA, we are trying to create a social environment and a school environment that is safe for children as far as possible. Yeah, those efforts will have an impact, and then individually take all those precautions I mentioned earlier. And I think together, put them together, I think we can handle and we can manage this virus.
The situation in Africa with children getting infected is likely to be very different from that in Singapore. While we have emphasized person-to-person transmission of infection taking place through physical contact, in Africa there are likely to be other forms of transmission. We have to remember that the mpox virus actually also exists in animals, for example in rodents, and the risk of exposure to animals is much higher in Africa than it is in Singapore. There's no known reservoir of mpox virus in Singapore within the animal population, rodents in Singapore. So on that basis, the risk of transmission into children is probably going to be very different in Singapore as opposed to in Africa. That said, the general measures that already have been put in place with ACDA and MOE against other infections like hand, foot and mouth disease all are relevant. And we have already been teaching our children on how to look out for rashes, especially if other people in the class have hand, foot, mouth disease, to look and to have this practice of good hand hygiene. In fact, all these are relevant measures that already are in place. What actually is needed then is to continue to encourage and remind our children, parents, about these safe measures that can easily be adopted by the children and in families as well. No special additional precautions otherwise need to be put in place.
Do you think there will be concerns amongst parents?
It's just because they're more elderly and are reading Taobao, so I think they will be very concerned about since the measures are towards a certain group than what the general public.
Okay.
Sorry, I just want to clarify in case I missed out. So currently our threat level is at outbreak management. Is that right?
Yes.
Just a clarification on the vaccination. It was written that the vaccination is for those healthcare workers working in close contact with Clade I cases. Then how about for Clade II cases? And those affected with Clade II cases.
Yeah, the main way in which healthcare workers should protect themselves is by personal protective equipment based on the case that they're seeing, as well as hand hygiene and good respiratory hygiene in general. So there is no need for the general healthcare workers to be vaccinated ahead of for mpox given the current situation. The ones that we have decided to give pre-exposure vaccination are those who we know are going to deal with suspect or even confirmed cases in the future if ever there's one. And we need to protect them because the risk will be higher than even the general healthcare worker community. And therefore, the healthcare workers will continue to protect themselves, not just from mpox, but other infectious diseases in general, through personal protective equipment and hygiene measures.
I think because it's a new disease, so we have a lot of questions, yeah, and uncertainty and asking why not protect this group and that group. I think we have to also see in perspective, there are also other diseases that we are living with already. And they are not, they can be severe for certain groups. Dengue can be dangerous, chickenpox can be dangerous. But we have been able to live with it as part of life without having to totally overturn the way we live. So likewise for mpox Clade I, it being new, we are paying some attention to it. We are responding to it, and as we know about it better, we will adapt our measures.
To expand on Minister's comments and directly to the question that's been asked, actually when we first saw Clade II infections, we did make an offer to healthcare professionals that were looking after such patients at that time to offer them vaccinations. But since then, the first case in 2019, the outbreak that took place in 2022, we've had no cases of healthcare workers being infected in Singapore as a result of looking after patients, and therefore it does testify to the adequacy of our protective measures to safeguard the welfare of healthcare workers. And it's generally been, again, hygiene, the use of personal protective equipment, that actually is the key towards protecting our healthcare workforce. And that's why we think that the current measures they put in place for safe care of mpox Clade II patients continues to be effective. But because Clade I infections are still relatively new, while we think that as the evidence evolves, it may not be that much dissimilar to Clade II, there's still an uncertainty that warrants a greater degree of caution with Clade I, and therefore that fresh offer for vaccinating healthcare workers directly looking after Clade I patients has been made. But we will evolve our policy as more information comes out, and if the evidence indeed shows that our healthcare workers are adequately protected with all our base measures put in place, then we will review the requirement for vaccination accordingly.
Yes.
I hope this isn't too basic a question, but you said earlier that mpox has an R rate of 1.3. To give us some frame of reference, do you think you could give us another disease's R rate, perhaps COVID-19's?
COVID-19 is 5 or 8. Yeah. What is SARS?
SARS wasn't that high because it was still relatively contained as a disease. But I think, for example, measles. Measles was a disease that we also use a vaccination for, and the R for measles can be as high as 10. So that gives you a sort of sense of how...
Chickenpox can go up to 10.
That's right. Chickenpox is airborne disease and can be spread quite rapidly as well.
It's a good question. A good question. put things in perspective. Judging from your question, I think maybe we should address this, which is, Kenneth mentioned we have adequate supply of vaccines, but it's not an infinite supply. We do have to watch the stock. Based on our current response plan, which we think is the correct one based on the characteristics, we have adequate supply that lasts us quite a while. Of course, if we change response to say offer it to everybody, then of course you're not going to have enough. No country have enough. Yeah. Considering that smallpox was eradicated, there's not a lot of supply in the world. We happen to have some stockpile. So, but I think more importantly is that what we have presented is what we think is effective. The mentality has to be important, which is 居安思危. 居安思危. We are living life as normally as we can until we can't help it. But at the same time, be mindful of the danger. Yeah, and be prepared to do things to counter that danger. So, if you think about, if we start offering vaccines to everyone that we think is vulnerable, first, I don't think there will be enough supply. No country will have enough supply for smallpox vaccine to do that. But I think it's not effective. You are somewhat wasting the vaccine, given that this is a R 1.3, right? And you'll be giving to so many, not enough, and it's not effective. I would say this is 事倍功半，你浪费了那个疫苗。Instead, we save it for those who have exposure. Yeah. So we contact trace, quarantine them, give them as a PEP. Yeah. And therefore, hopefully they won't develop symptoms, they won't get infected. And that way we suppress the R hopefully below 1. Then overall, we are fighting the war much more smartly. And that way is 事半功倍. Yeah? It's much more efficient, more effective for us to use the vaccines that way. Yeah? So in case everybody going away thinking that this is a matter of supply, yes, supply will be an issue if you want to give to everybody. But based on the characteristics, based on strategy, I think this is the right way to do it. And based on this strategy, we have enough supply.
So the contact tracing for mpox Clade I, it's small enough to trace physically and not use the trace together.
Yeah.
Just getting this right.
Yes. Yes.
Right. It's also because of how the disease is transmitted. And so the type of contact we're looking at tends to be, for example, within the household. And then maybe some others may be a bit more specific to certain interactions, but we think that the physical contact tracing approach is okay.
Bearing in mind for COVID-19, we relied on physical contact tracing for quite a while. Yeah, before we had a more infectious strain and we had to resort to trace together.
Also for the Clade II outbreak in 2022, we continue to rely on physical contact tracing without the need to adopt digital methods.
Okay. All right. Any last questions? It's okay.
So you're asking about context for Clade II cases? Yes. So for close contact of mpox, whether it be Clade I or Clade II, we do offer the post-exposure vaccinations for that. Yeah.
It's the same vaccine?
Yes, it's the same vaccines.
Okay. Okay.